Yes, I'm going to talk about medications today, and I'm not a researcher yet. We're just beginning to start up some clinical research as part of a lifestyle psychiatry clinic that's starting up in about 2 weeks. But for now, I wanted to talk about the obesogenic brain. I've got to say Dr. Peters chose this title. He wanted to talk about how the brain can trick you into gaining weight and staying overweight despite your best efforts at diet and exercise when you're on specific medications. So let me see how here it is. Okay, no conflicts. Okay. Let's see, it's skipped quite a bit. Okay, so today just going to look at 3 things. Let's see. Is this the right one? So it's this one. Okay, so I was going to describe some common obesogenic drugs, explain some of those mechanisms, and also learn what to do if your patients are on these, where to go, what to do. So just start. Okay, so obesity is a huge issue, no pun intended, but in the United States, prevalence is around 38%. And by 2030, just 10 years from now, it'll be up to 51% of the population, including kids. I work with kids, so this is really relevant to them as well. And when we talk about obesity, we're not referring to just the cosmetic problem. I guess all of you know that. It's medical. Can lead to heart disease, stroke, diabetes, high blood pressure, all kinds of other problems, including infertility. So anyway, as we know, the cause of obesity isn't just this formula, calories in, calories expended. Certain medications can also cause it. In fact, many medications can cause it. And I think Dr. Peters wanted a psychiatrist to give this part because many of the medications are actually psychiatric medications that are kind of among the worst. So among those medications that are really, really awful for weight gain, you have here, this is actually not the same image I'm seeing there. We have here antidepressant medications, antipsychotic medications, mood stabilizers, anti-epileptics, steroids, blood pressure medications, and diabetic medications. See, these aren't, it's not the same image here. It's up there. But thank goodness, I'll just try to use what's up there. It's okay. It's okay.
Because that looks like that screen is the one there.
Okay, and what's this? That should be it. I guess I can just, can we move this over a little bit so I can see? Pardon me. Okay, or I can just kind of try. Okay, great. Okay, thank you. That'll be, is this also? Oh, click in there.
Oops. Try that again. There.
Oh, okay, good. Okay, great, thank you. Okay, so right, your patients may hear in the news that it's no problem. You can combat the weight gain from these medications just by diet and exercising. A few pharmaceutically backed studies with big conflicts of interest say that this is the case, that you can just lose weight nevertheless as long as you diet and exercise, but this isn't always true. And what we clinicians notice is that sometimes that medication-induced weight is really hard to lose. Sometimes it can't be lost at all while you're on those medications. And sometimes the weight gain actually is permanent. It doesn't go away even after you've gone off the medication. So here are some studies in which these things were shown to be true. We have up here one by Lind in 2004. Being on antidepressants predicted very poor weight loss on the part of obese women. Same thing, Skrinar, there was no significant weight loss for obese people with mood or psychiatric disorders, despite being in one of those weight loss programs. Pagodo, 2007, less weight loss among obese people on antidepressants than not on antidepressants. Bonfioli, a meta-analysis of obese individuals on antipsychotics, even when enrolled in weight loss programs, diet and exercise, they didn't lose significant amounts of weight. And then Imeyama, less weight loss among obese antidepressant users than among non-antidepressant users. So, so here's another study. This is the largest study of its kind. Dessa Yermos in 2019 did a really big VA study, 650 people. So they were put on a really vigorous weight loss regimen involving diet and exercise. And to his surprise, you know, these patients enrolled, and it turned out 62% of them from the get-go were actually on medications implicated in causing obesity. And those who were already on those medications were 40% less likely to lose significant weight. And if you're on 2 or more of those medications, the odds keep going down in kind of like a dose-dependent way with persistence of that overweight. Okay, so what are the mechanisms? Well, we just heard about some of them from our 2 previous speakers. But I just wanted to say, I don't think it's just molecular mechanisms. These obesogenic medications in and of themselves could be implicated. For example, in the U.S., prevalence for using an SSRI antidepressant is at 25%. So if 38% of people are obese, you know, 25% alone are on SSRIs. And what about other classes of obesogenic meds, the antipsychotics, the antihypertensive, the anti-diabetics? When you add all of that up, you know, you get this question, could it be the epidemic of obesity actually is tied to the development of the increasing use of these obesogenic meds? You know, could the obesity epidemic in part be iatrogenic? Are we doing it? Is it like not, you know, obesogenic genetics or obesogenic taste buds or the Western diet or whatever, but actually obesogenic doctors? So, okay, so moving on to our second point. So what are these mechanisms? Okay, so we have, as we already discussed, increasing ghrelin and other hunger hormones so that the hunger is intense, decreasing leptin and other satiety hormones so that the patient's appetite is less satisfied, changes in molecular brain signals, triggering carbohydrate craving, preference for calorie-dense refined foods and fatty foods, ingestion of high glycemic load starchy carbohydrate foods that trigger high levels of insulin release, promoting fat storage. Okay, and then also, you know, alteration of the number or size of adipocytes, sedation, simple sedation, resulting in down-regulation of your energy level, desire to exercise, down-regulation of thyroid and other organ function, and probable other molecular mechanisms. But anyway, the point is that the medications themselves could be triggering these known and unknown mechanisms. So moving on to what you can do, just very briefly, my best advice is to talk to patients about the medications they're on, consider whether they might be, you know, obesogenic ones, and consider the risks and benefits. You know, with psychosis, we're kind of between the rock and a hard place. Obviously, remaining non-psychotic is a more important thing than the other one about, at least short term, than the weight gain. But really consider, do the patients need these medications? Can you switch to another one? Sometimes you can even switch to a medication or add a medication that encourages weight loss. So, but really what we recommend is to go to, refer them to a physician-run weight loss program, such as the one we have that Dr. Peters runs here at LLU. And this is really your best chance at outwitting the obesogenic brain. You know, as you know, a lot of information out there on the web actually goes contrary to the science. And it's only, you know, a physician-run program, you know, where you're going to be able to ask those questions and have those answered, and get into medications that can really help. So, I'm going to show some alternatives to non-obesogenic medications. I don't know how many of you are in psychiatry are going to be using them. But for example, if you're going to use antidepressant medications on your patients, very commonly given out in primary care, the two best ones are probably sertraline and fluoxetine. Sertraline, Zoloft, is the one with really not associated with any long-term weight loss. Fluoxetine Prozac is good at first, but eventually you'll have weight gain even with that. So among antipsychotic medications, the worst offenders are really clozapine, olanzapine, risperidone, and quetiapine. But you can switch those to other antipsychotics. There are a couple that aren't as bad as the others. Ziprasidone, Geodon, purportedly weight neutral. Actually, I've seen a little bit of weight gain even on Geodon. And lorazepam, Latuda, way newer one. Now, Abilify is marketed for its kind of weight neutral properties, but actually what you see clinically is people do gain weight on Abilify actually quite rapidly, not as bad as these other four that I mentioned. Those are the big four. Then for mood stabilizing medications, lithium, obviously, you gain a lot of weight, but you can use lamotrigine, which is Lamictal, or you can use topiramate, Topamax. For the anti-epileptic medications, you can use the same ones. You can move from Depakote, gabapentin again to Lamictal or Topamax. Okay, and for the steroid hormones, there really is no completely reliable way around those, but there are some natural, fruits, herbs, foods that help raise concentrations of either estrogen or testosterone. To raise estrogen, you have, flaxseed meal, soy, certain fruits and nuts, black cohosh, red clover, dong quai, evening primrose, ginkgo, ginseng, and some others. For testosterone, there are quite a few as well. Acetyl L-carnitine, L-arginine, Panax ginseng, Tribulus terrestris, and a bunch of others, especially Mucuna. We use that in the weight loss clinic here. Wild yam, maca root, etc. Generally though, although those are helpful, there's no real substitute. So for the blood pressure medications, we have the newer beta blocker, carvedilol. And for non-insulin diabetic medications, you're left with metformin, also liraglutide and empagliflozin, especially in combination with dietary changes and exercise. So, all right, and among the best medications for, limiting weight gain, encouraging weight loss, we have orlistat, phentermine topiramate, bupropion naltrexone, and you can also just refer patients to a weight loss clinic. There are some herbal ones, herbal appetite suppressants with some evidence of efficacy, basically anything with soluble fiber like oats, fenugreek, Garcinia cambogia, Griffonia simplicifolia, hard to pronounce, green tea, yerba mate, and coffee. Those are all somewhat helpful. Okay, but basically, obesity care providers can tell you a bunch of things that would not be kind of reliably obtained on the web or from a non-specialist. They can tell you what types of foods contribute to insulin resistance, the types of exercise that might be appropriate given your weight and overall medical condition, weight loss options that are kind of unusual, meal replacements or patterns of intermittent fasting that might be helpful. And they can give you options for mental health counseling. So in summary, if your patients are obese and trying to lose weight but can't, it could be that they're on one or more obesogenic meds, tricking the brain into making and keeping them overweight. There are medications that can assist with weight loss, and to lose weight, the best plan really is to refer to a specialist who can tell you about the right medications, the right diet, good exercise routine, and possibly, intermittent fasting options or other regimens that'll help. And that'll really give your patients their best chance of outwitting this obesogenic brain that we all have. So thank you.